It's wonderful to see you back. Now, this is very interesting for me. It is now the middle of the night, and you could be all over Athens having fun. The problem is I don't know how to say good evening in Greek, so all I can say is yesas. Is that hello? Thank you. We're going to do Greek lessons in public. You want to make me feel even worse. Thank you for that. So and the other thing is I have headphones this time, so they're translating me into Russian at the moment. So and also I can listen to the Scottish football tonight because we are 2 hours behind. So if I need to, I will listen. And if anyone wants to listen to Scottish football, please feel free. So so what I want to do now is actually pick up from where I finished just an hour or so ago, and I want to talk a little bit about psoriatic arthritis in the bigger picture. And what I want to do is to have you think a little bit in the first instance about the clinical challenge. And I'd like to give you a hypothesis which I hope will be helpful to you in managing this very complex disease. So the things for those of you, and you know, I do like to give the key points to you at the beginning of each little section of this lecture, so that when you sleep, you still get your CME, you still remember. So the 2 points here are that this is a disease of many tissues. And many tissues have distinctive pathology. And the key point here is that we should not expect every tissue to behave the same way when we give any individual medicine. And that is indeed what we find in the clinic. And that can be quite confusing. So this is an easy slide to start with. This is psoriatic arthritis. Everybody recognises it. Oh, this is the one I broke earlier. Sorry about that. I'll use the mouse. So here we are, classic psoriatic arthritis. It is a disease of at least the synovium, the enthesis, the bone, and the skin. So that's easy. That's a straightforward bit. But even in those tissues, so look within the skin. So here is what dermatologists call psoriasis. And I always give them a very hard time. How can they possibly look at this and call this the same as that, the same as this, the same as that? They look very different to me. So when I look at those rashes, they look different. But the dermatologists are much cleverer than rheumatologists. So I was at a dermatology meeting in Vienna recently, the European Dermatology meeting, and it's the only meeting I have ever gone to where one of the stands, when you registered, said, "Where do you put your private jet?" So you know you're at a dermatology meeting, because they all have, and net jets were advertising at their meeting. Dermatology, plastic surgery, cosmetic surgery. So they're different animals from us. So they just look at that and they just say, that's all psoriasis. And then even we know we have to think about the eye. We have to think about the gut. And actually we have to think about much more than that. We have to think about the heart. We have to think about the blood vessel. We have to think about the brain. And I particularly want to emphasize the comorbidities, or as they probably should be more appropriately termed, the multimorbidities, because it is far from clear that these are simply secondary phenomena, especially in psoriasis and psoriatic arthritis. We're beginning to understand that the mechanisms that drive, for example, metabolic syndrome in psoriasis and PSA may be different from the mechanisms that drive that state in rheumatoid arthritis. So if you look, for example, here, this is a study from last year in the Annals of Rheumatic Diseases, and what you're seeing here are MACE, the major adverse cardiovascular events, in the UK GP registry allocated to different diagnostic groups. Now, because it's UK data, the only place you can get it is in Harvard, because they bought up all the rights. So actually, when we want to go and examine this cohort, we have to pay Americans money. So I don't know who did that deal. ideal, but that's always a bit frustrating, to be perfectly honest with you. But it does mean that very smart people like Dan Solomon and others can interrogate the data and tell us really smart things about it. But what you have to notice here is that if you look, there we go. So if you look here, the event rate is quite a bit higher than normal for people with rheumatoid, psoriasis and psoriatic arthritis across different modes of action. So you've got to think about that. So when you see a patient with psoriasis, psoriatic arthritis, it's at least as important for you to think about their metabolic state as it is about their inflammatory state. If you don't, you're not treating the whole person. What about the brain? And I want to just show you one, for me, quite startling image. So for many years, we've been interested in Glasgow in the brain. There's quite a big debate, actually, in Britain about whether people from Glasgow have a brain. So the first thing we did was to image our patients, and we were able to persuade everyone in London that we did indeed have brains. So then we had to find out whether they functioned or not. And the evidence against is that we continue to support the Scotland football team. That's not evidence of functioning brain at all. But hey, there you go. So what we did was, everyone who's an active clinician knows that when you give a TNF blocker to people with rheumatoid and psoriatic arthritis, they very often feel better before they look better. You've all had these patients who will tell you even a day after the first infusion or injection, I felt better, but your joints hadn't changed, your skin was up. No, but I felt better. Believe me. So what we did was, we've done a whole number of studies now, but we imaged the brains of our patients before and after giving them a TNF blocker, in this case etanercept, and we measured their peripheral circulating cytokines. And what you're looking at in this image is the serotonin transporter availability in the brain correlating to peripheral circulating TNF-alpha levels. And I think that's extraordinary. I actually can't explain this observation yet. And when we actually looked at serotonergic function in the brain, and this is SPECT scanning in the brain, I don't know if you can see it in this light, but if you look here, pre-treatment above, post-treatment below, there is more orange colour here than there is here. And it turned out that that was the case in every patient. And when we then looked, and this is a statistical analysis that allows you to look at the Beck's Depression Inventory. That's a questionnaire that determines whether you're depressed or not. And that's the one that's been most highly validated for use in rheumatologic practice. And you compare that to the concentration of TNF and to the serotonin transporter availability. So that's Prozac. That's, dopaminergic and serotonergic signaling in the brain. It turns out there's a direct relationship. So what do we infer from this? When your patient with psoriatic arthritis says to you, I feel depressed, they may well be reacting to their state, because nobody's happy that they have a skin disease and a joint disease and an enthesial disease, but they may also be telling you, I have an inflammatory state in my hippocampus and dentate gyrus that is part of my disease. Please treat me appropriately. And for that reason, we now have a very strong focus on psychological function, metabolic function, skin function, and musculoskeletal function. So my psoriatic arthritis clinic is a true multidisciplinary team. And it's not because we feel sorry for people who are saying, oh, I feel depressed, I've got psoriatic arthritis. They're coming in and saying, the manifestation of my disease is skin disease, joint disease, and brain disease, or skin disease, metabolic disease, and tendon disease. And we need to separate those tissues out to properly treat the patient. Properly treat the patient. What do I mean by that? Well, let me just give you an example of properly treating the patient. If you're going to properly treat somebody, you need to understand each tissue compartment and then treat that tissue compartment effectively. So, just for those of you wondering what the slide is, there we go. This is an Australian road sign, water on road during rain. clearly written by a Scottish person visiting Australia, just to help the Australians out. They're not the fastest, you know. And this is a Scottish summer day, beautiful mid-July weather in Scotland, near where I live. You think I'm kidding, that is mid-July in Scotland. You know that because the grass is green and not brown. You don't really know the change of season. Winter, it's snowy and icy. In summer, it's green. But the cloud is always the same. So there we are. So to state the obvious, the skin, the gut, the eye and the joint are different. And the immune system has evolved over millions of years to make different responses in those different tissues. So the skin and the gut are full of bugs. It's called the microbiome. It is adapted to have lots of bugs in that tissue. That's how the immune system is designed. The eye is sterile, and so too probably is the joint. And therefore the local immune response that we will mount in the skin will be different from the one that we will mount in the joint. So we should not make an expectation that when we give a single antibody against a single cytokine, that we will get the same response in the skin of the joint, because the responses are not meant to be the same. And it's actually very interesting. When you start to look at the kinds of cytokine responses in the skin and joints of people with psoriatic arthritis, the skin is an IL-17 dominant response. The joint looks much more like a TNF-driven response. Isn't that interesting? And that's because these different tissues have adapted to deal differently with responses. The eye is sterile. You can actually have a big rash in the skin and still survive and still heal. If you have that same volume of inflammation in the eye, you will be blind. Evolution couldn't tolerate that, and so the immune system had to change. So now let's go into the clinical phase of what we do, but let's do so with a very different view. The view I want you to have now is that we need to think of the pathways in each tissue and treat them with respect. And what we do in the clinic is we actually separate out each clinical tissue compartment and we treat them sequentially in the clinic. Okay, so I'm going to tell you now about guidelines. I already showed you the EULAR guidelines tonight. And what I did was I heard some questions and I put some data in to give you the answer to the questions that I heard earlier on today. So this is called, it's not adaptive trial design, it's adaptive lecture design. Okay, so I hope that some of the questions that came up earlier, I put a little bit of some of the answers in here. It was either that or go and drink coffee. And you know, who wants to drink coffee when you could be writing a lecture? So here we go. I'm going to tell you about conventional TNF blocking drugs. I'm going to very briefly remind you about IL-17. I'm showing you a little bit about the IL-12/23 pathway, and fresh off the press, some data about small molecules. So here are, I showed you the EULAR guidelines. Here's the GRAPPA guidelines. Now, the major difference between GRAPPA and EULAR is that GRAPPA has accepted the principle that different tissue presentations probably need a different response. And I must say, I quite like these new GRAPPA guidelines. They appeal to me. I think the authors have done a really good job. I like the EULAR guidelines as well. But I think what the GRAPPA guideline has done that's maybe a little different is to separate tissues. So for example, you could look at axial disease here, you could look at dactylitis, you look at skin, and you just follow the algorithm down. The font is small, the hour is late, the need for detail is very small indeed. But let's just accept that different tissues give us different opportunities to treat. So what about conventional disease-modifying drugs? What is their contribution to the musculoskeletal compartment? The evidence base is dreadful. It's astonishing that we are using methotrexate, sulfasalazine, leflunomide, and sometimes even other conventional disease-modifying drugs against a literature that is really only single-figure number of trials in 2016. It's extraordinary. And the only properly constructed randomised controlled trial to look at methotrexate in psoriatic arthritis, the MIPA study, missed its primary outcome. It did not confirm that methotrexate worked in psoriatic arthritis. So this is a pretty serious situation. But that's the totality of the evidence base. You can see the number of randomised controlled trials, the total number of patients, and compare that with some of the biologic studies that we have already seen tonight and we'll look at just in 2 or 3 minutes. The main outcomes you can see I put in bold here. The bottom line is that these drugs probably work, but that their differentiation from placebo is narrow, and their focus is almost exclusively on the joint, with the exception of methotrexate and cyclosporin. Okay, I showed you this slide already today. Let me now work our way, and we're going to do this from left to right. And what we're going to do is we're going to just think logically about each of the modes of action that we have available now, and I'm going to show you the key data that you need to have in your mind. And at the end of 10 minutes, you will have each of the core studies that you need to have in your mind to guide your practice. Very simple. I'm a very simple man. Life is easy in my life. So, TNF blockers, you know them all. Here are the data. So what I've done in one slide is put each of the pivotal phase 3 trials in one place for you. And you see here that the outcomes, adalimumab, certolizumab, etanercept, golimumab and infliximab, what you can see is that the general 50 to 60% rule for responses to a TNF blocker in PSA were consistent across the studies. So, what do we get from that? We get that if we can get a response between 50 and 60% to other modes of action, we're probably in the same ballpark. These drugs transformed the treatment of psoriatic arthritis. We got to them sort of by accident, but let us not diminish our excitement for all that. The minimal disease activity score is an equivalent of remission. It's a combination of swollen tender joints, psoriatic disease activity, in the skin, psoriatic disease activity in terms of impact on function, and also a couple of other measures of quality of life. And the idea is that if you can achieve a proportion of those outcomes, you will be judged to be in minimal disease state. And the reason that matters is because if you are in an MDA, you are less likely to progress, and you are far more likely to stay in a stable functional condition. Picking up one of the questions Dimitri asked earlier on today. These are people, if you can get to an MDA, you will do better. So it's worth achieving. And for TNF blockers, we achieve that state through 2 or even more years in just around 50% of patients. Now this is where you have to remember you've got a Scottish person with you. I actually am a bit disappointed. 50% of people, or 60% of people, are not achieving an MDA. That's not good enough. It's nowhere near good enough. Our patients, quite rightly, are telling us, do better. And the other thing to say is that means a lot of people stay in a TNF blocker with imperfect responses. And these are Danish data. The updated data look pretty much the same from last year. You see here the number of people staying on their TNF blocker, and you can see here that after 4 or 5 years, around half of patients are off the drug. This is a disease whose age of onset is in 20s and 30s. It's not like rheumatoid, 40s, 50s, 60s. This is a disease of males and females at their most economically productive time, at a time when they're bringing families at a very young age into the world. And after 4 or 5 years, half of them are off their generally considered first choice biologic. What is that all about? Are we satisfied with that? I'm not. And I suspect many of your patients aren't either. And there's some interesting stuff in here. Some of you probably know, I'm very intrigued by this. Men stay on TNF blockers longer than women. Why is this? Is it because men are patient, loyal people who look after the relationship with the doctor, stay on the medicine, hanging in there because they know that that's what they need to do? Or is it because women are discerning and asking far more difficult questions of their doctor and generally much wiser? I asked my wife. She told me it was the latter, not the former. And who am I to argue with her? Certainly I'm not going to argue with my wife. I suspect there's probably real biology in this. This has been shown to be the case for skin responses as well. Okay, TNF blockers were borrowed from rheumatoid, so was abatacept, so was tocilizumab. Tocilizumab didn't work. Abatacept worked a bit. The data were shown at ACR 3 weeks ago, and the top line responses are around 40 maybe % or so. Not a terribly impressive trial outcome. And this makes the point that rheumatoid and psoriatic arthritis really are different diseases. They're genetically different, they're clinically different, they're histologically different, they are immunologically different, and yet we have simply been treating them as if PSA was rheumatoid with a rash. Drug works on rheumatoid, give it to PSA. And that's why, and forgive me for making this, this is one of the very few remarks I'll make that double up, but I want to emphasize that the real advance in ustekinumab and apremilast and in IL-17 blockers is that we're finally deriving medicines based on the primary pathogenesis of the disease rather than just borrowing drugs from other disease states. That's a completely different approach and is very exciting because some of them are working, and it gives us cause to believe that if we kept understanding, we would find new medicines down the line. I'm very optimistic about this, and you all remember Steve Jobs. Do not be trapped by dogma. Do not live with the results of other people's thinking, and I think the PSA field has grown up. So here are the magnificently named IL-23 blockers. You ready for this one? Guselkumab, Tildrakizumab. I've been practicing all year for Tildrakizumab. I can say that even after a glass of Greek wine, without stumbling. It's true, I practice. Both, by the way, the Greek wine and the pronunciation. Ustekinumab blocks P40, which means you block both IL-12 and IL-23. And when you do that, this is what you find. This is the Summit 1 and Summit 2 trial. Summit 1 were biologic naive patients. Summit 2 were about a third of them had previously seen a TNF blocking medicine. And you see here the ACR 20, 50, 70 responses, around 50%. So just a little, couple of points below what we saw with the TNF blockers. And that is borne out, I think, in clinical practice, in fact, with ustekinumab. Great drug in the skin, and it works in the joints. It also is radiographically protective. Hard to see maybe with the colour scheme that's come up in the font here, but here are the placebo, here are the actively treated patients, and you can see this little triangle here separates, and that tells you that this is a protective medicine. And also we see with ustekinumab quite robust and very satisfactory responses on enthesitis that I'm showing you here over time, week 24 through 1 year, 2 years. I could have shown you very similar data for dactylitis had time allowed, but this drug works. It is radiographically protective, it is very nice effects on enthesitis, dactylitis, and is a modestly effective anti-synovitis drug. Now, I have already had the privilege of spending half an hour on IL-17, so forgive me, I'm simply going to remind those of you who were here before that IL-17 inhibitors come in 3 forms at the moment. IL-17A inhibition, which is secukinumab, and ixekizumab. Secukinumab is approved. And the alternative approach to the IL-17 pathway is to use brodalumab, which blocks the receptor. Now, the key difference here, remember, is that the anti-cytokine antibodies only block IL-17A and a little bit of 17F, and the cytokine receptor antibody blocks a whole family of IL-17 molecules, 6 of them. So the biology might not be the same. And recall that brodalumab's development has been interrupted because of concerns about suicidal ideation. But now, based on the data that I've just shown you, you'll be saying, but hang on a minute, McInnes, could these patients have had suicidal ideation because they were depressed? And the answer is, of course they could have. And that was why that study was so hard to interpret. Okay, so I've shown you these data already, so forgive me for brevity. The Future 2 study, secukinumab subcut delivery to people with PSA, the 150 and 300 milligrams overlapping, and again you see between 50 and 54% of ACR 20 responses. And these are absolutely the same time points and primaries that I showed you for the TNF blockers 5 minutes ago. I've done that deliberately to let you see that the numbers are about the same. and the patient populations are about the same. And just to remind you that in a pooled analysis of the FUTURE-1 study, that secukinumab was also able to prevent erosion, and again to remind you that dactylitis and enthesitis were very favourably affected by the use of drug. So all of that is a reminder. For those of you who weren't here earlier on, I hope you had a great time out at the shops. But you now know everything that everyone else was, and you're feeling really happy, aren't you? Because you're saying, I went shopping and I still know what everyone else knew, and they had to sit here for half an hour. Tough. And just coming towards the end, we have new medicines to play with. We have small molecule inhibitors. We have a Premilast, which is a PDE4 inhibitor, phosphodiesterase inhibitor, and we have baricitinib, a JAK kinase inhibitor, and tofacitinib, a JAK kinase inhibitor. I'll show you the currently available data, a Premilast, PALIS-1, PALIS-2, and PALIS-3. First thing to notice is that 30 milligrams BID of this drug is better than placebo. The second thing to notice is that the total response rate is only in the high 30% at ACR20. So this drug only works in a smaller number of patients than the biologics. But I will tell you in clinical practice, if you're a responder to a Premilast, you generally stay a responder. So I think there probably is an endotype, a subgroup of people who can respond pretty well to this medicine. It also has a beneficial effect. You're looking at Maastricht enthesitis score, dactylitis on the right, and you see the blue is placebo and the green here is the 30 BID of Premilast. So it works also at a modest level in the enthesis and dactylitis space. And finally, hot off the press, 3 weeks old, the Opal broaden study, Phil Mee showed these in Washington just a few weeks ago. So either you could go to Washington and celebrate with Mr. Trump, or you could stay in Athens and see the data 3 weeks later. Your call. So 422 patients received either 5 or 10 milligrams BID TOFA, and you see the ACR response was around 50% in the dose that we have been accustomed to using safely in rheumatoid patients. Looks very similar, therefore, to what we've achieved with other modes of action. This was the radiographic non-progressors were about the same in the groups. The adalimumab comparator arm, this is a real gymnastic exercise. It wasn't a comparison, honestly. But in the same trial, there was adalimumab recipients and tofacitinib recipients. But statistically, it wasn't a head-to-head trial somehow. I don't understand that. And the SAEs were pretty much what we'd expect to see. And just finally, before I close, I want to talk very briefly about treat to target. So treat to target, everybody treats to target, supposedly. And in rheumatoid, there's pretty good evidence base to suggest that treating to target's a good idea. So a whole lot of people, and this is just out of focus, so you don't know who they are. Good job too. Because all of these really wise people decided that we should treat to target in psoriatic arthritis. Does anyone recognize this cartoon? Does it look familiar? So if you kind of scribble out SPA and write RA, does it look pretty much the same? That's because it is pretty much the same. And the problem with this is that there was absolutely no data whatsoever to support that recommendation. And the concept of disutility springs to mind. If you use statins too widely in the population, you actually will increase the risk of developing diabetes. If you overuse and that's very counterintuitive, but disutility is the concept where too much of a good thing stops being good. So this is from a wonderful book Malcolm Gladwell wrote recently, David and Goliath. This is about parenting. Parenting can be, and in the book it's easy or hard, but all of us with children know that it is never easy. So I changed it to easier and harder, okay? Because nobody is going to tell me bringing up children is easy. I've got 2 daughters and oh my heavens. Right, if you earn $75,000 a year, that is the optimum income to bring up children successfully. If you're very poor, it's very hard to bring up children. Everyone understands that. And apparently, if you're very rich, it's also really hard to bring up children. You know, and we're coming up to Christmas. Daddy, I didn't want a Lamborghini, I wanted a Ferrari. Take it back. And I wanted a red one, not a blue one. I'm very upset with you, Daddy. The private jet isn't the colour I wanted. Daddy, get me another private jet. Presumably these are the children of dermatologists, but hey, what can we say? So this is the disutility hypothesis. It's very difficult to have too much of a good thing. We need evidence that a treat-to-target approach helps. And fortunately, Laura Coates published just such a study. So this is in the Lancet last year. So the red group were treated to a tight control regime, and the grey group were treated to standard of care. And you see that the tight control patients did better. But unlike any other strategy trial, the SAE event rate, so the serious adverse event rate, was higher in the tight control group than the standard of care. So it's an open question whether tight control is the answer. So let me close, ladies and gentlemen, by thanking you for your attention. Let me close by gently challenging you with the following. Hands up who has a psoriatic arthritis clinic. Oh dear, oh dear, oh dear, oh dear. Well, we failed that little test. Hands up who thinks they might like to have a psoriatic arthritis clinic to deal with this multi-morbid disease. That was a clue to put. Thank you. Oh, thank you so much. Somebody put their hand up. You are quite wonderful. Thank you for that. So, who's driving the patient? Who's in control of the disease? So this is my favourite slide. The patient is confused in the middle because they go to the clinic and they've got horrible skin disease and they see a rheumatologist who says, your joints are fine. And the patient goes out and they've still got horrible skin disease. So they're not well, but they were told by the doctor that they were. Patients, and we've asked them, find this really confusing. And actually, I have to say, for the dermatology meeting I was at recently, I did change the slide, and I became the black sheep, because I was the only rheumatologist in a room full of 4,000 dermatologists, and I was very bad. I did talk about private jets, and they weren't happy at all. So this is my closing slide, ladies and gentlemen. The thing I'd love you to do is to go back to your clinic, think about each tissue compartment, treat it on its own merits, because at long last we have agents available to do that. Thank you very much indeed for your attention.